Thank you, Stuart. Thank you to Dr. Ronco for having organized the pediatric session at least. I'll go quickly talking about my outline. I will tell you about how many patients are put on a circuit, as David just said. What is the importance of timing for these patients, something about vascular access that we know is so important in this cohort. I will talk about dose and fluid control. As you can see, these are capital letters, and something about specific setting. Probably you'll know a lot about these two milestone studies that have been anticipated by previous speeches. And what I wanted to highlight in my slides was the incidence of CRRT, or at least renal replacement therapy in these studies. In the AWARE, 73 patients, that is 1.5% of patients, were treated by RRT, so not many, but the risk for mortality in these patients was really high, independently higher than the rest of the patients. And the same is for the neonatal study, where 1% of patients were treated by renal replacement therapy. As you can see here, various modality, prevalently CRRT, but many peritoneal dialysis. And here the numbers come again with an increased risk, independent and really high increased risk for mortality in these patients. This other study was conducted in the UK, and these are many years of data collection in the UK PQs, and they collected data about hundreds of thousands of patients. And what they found out was that in the UK, the incidence of RRT is 2.9%, so maybe a little more. But what is interesting in this study is the significant difference among different centers about the use of RRT. As you can see, there are some low volume centers using a lot of RRT, whereas high volume centers using low incidence, low rate of RRT. So this is to say that probably the indication for RRT is not really standardized even in the UK. Another interesting message from this study is that a lot of peritoneal dialysis is used in neonates, but also in older patients. And interestingly, what they found was that peritoneal dialysis was associated with improved survival. Again, probably this is a sort of bias that is linked to the fact that peritoneal dialysis is used with a different indication from extracorporeal therapies. Again, older age is associated with improved survival. So when you go and put all of this stuff together in a multivariable analysis, you end up by realizing that neonates are the most delicate part of this cohort and those with the highest risk of mortality. So the message here is the mortality of patients treated by RRT, either they are pediatric, infants, or neonates, is really high. Another important aspect of incidence of mortality in these patients is fluid accumulation before starting RRT. And as you can see from this other very important study coming from the registry that Stuart Goldstein has organized, as you can see here, every single drop of additional fluid overload that you give to your patient before starting RRT is increased with a mortality incidence. So the final numbers are from 30% to 65% mortality. Very wide variation, but still high regardless of the fluid overload. So let's talk about timing. We've learned from the adult studies that timing is such a controversial issue. There is not much about children in the literature. This is a quite important retrospective study that clearly told us that if you start renal replacement therapy in a shorter time after PICU admission, and this is an issue that the definition of timing here was distance from RRT start from PICU admission, but again, if you start earlier, you save more patient. Again, the definition of timing and the distinction between timing and RRT indication is very important, and one of the results of this study that I like pretty much is the fact that they realized that if a patient is admitted to the PICU with a higher P-rifle stage, then the possibility of surviving is significantly higher with respect, for example, to patients who have a progressive slow worsening of their renal function. So two messages here. The indication probably is more important than timing, and probably the need for new biomarkers will be important for RRT start in these people. Again, indication and timing. When you have cardiac surgery, you have both together because you know that cardiac surgery is bad for the kidneys. So an idea could be to start RRT soon after the surgery, as this French group has done, and as you can see, early PD in these neonates was effective in managing fluid balance and improving outcomes of these patients. That's a similar idea to the group from Cincinnati. They randomized two groups to receive soon after surgery either peritoneal dialysis or diuretics. So the peritoneal dialysis group didn't receive any diuretic, and the idea here was to see if there is a way to control fluid balance in an alternative way than giving diuretics. And as you can see, what they showed was that probably peritoneal dialysis was as effective as diuretics, or probably better in controlling fluid overload, but also the delayed extubation and prolonged cardiac ICU stay. So very effective. So let's move to the vascular access issue. We know from the registry that we probably have 2 or 3 sizes available for these patients, moving from 7 French for neonates to 10 or 11 French for older small adults, let's say. Probably these data are not universal. The UK group again showed us that you can reliably use even smaller catheters, even in neonates, especially when you select the internal jugular vein in order to deliver your treatment. But another important issue is a technical one. When you are using a vascular access, probably the pressures that you're watching in your display, in your user interface is not everything, because in these two cases, in these two machines where we initially prescribed the same blood flow rate that was very low, this is a very small neonate, 12 milliliters per minute, you can see the access and return values are quite similar, but the point is that when you use a non-adapted machine, you have big roll pumps that when oscillate cause a wide variation in positive and negative pressure during the rolling of the pump and the strokes. Reasonably, when you're using a miniaturized, dedicated roller pump, these oscillations are really less wide, and then even if the machine is cutting the pressure that you're seeing in the monitor, otherwise you will have numbers that goes up and down. But the difference is that you probably have some gap, some difference by using a dedicated versus a non-dedicated machine when you have a small vascular access, and this gap might save your treatment and might allow you to use smaller catheters. As I was saying, there are a lot of non-dedicated machines who apply pediatric circuits. Probably third and fourth generation machine are quite accurate even for smaller patients, but today we have some alternatives that have been conceived for smaller ones, and as I told you, smaller ones are those with the highest mortality risk. So probably this effort from the industry is so important at this stage. As you can see here, the Carpe Diem machine that is available in the market in Europe, the Newcastle machine, which is available in the UK, and the Acute, that is the machine that David just showed you. Just moving quickly to the prescription issue, I just wanted to touch upon this because it is important to know that the smallest is your patient probably, and the highest is the relative prescription you have to make to your patient. Even if the KDIGO guidelines that are conceived for adult patients recommend currently 20 to 25 milliliters per kilogram per hour, it is plausible that this is not enough in a small guy. And that's why, for example, probably we know from the registry that especially neonates in the US receive the highest prescription and probably higher than the commonly prescribed 2 liters per hour per square meter, and they go up to 3 liters. What I'm a little obsessed from is the fact that not necessarily prescription in liters per hour per 1.73 square meters is equal to the 35 milliliters per kilogram per hour. Especially in smaller patients, this ends up in a threefold different prescription, and this in terms of blood flow rate and difficulty of using a vascular access is so pretty much important. So the issue of adequacy in this patient is an open quest. Another important thing is that when you use the Ronco's number, which I'm particularly linked to, that is 35 milliliters per kilogram per hour, and you apply that to the KT over V, which is a nephrological number that tells you how many times you wash the volume of distribution of your patient. Well, in a neonate, you obtain exactly the number of 1. So it appears such a quite adequate way of indicating prescription. And in this study, we recently realized that in a cohort of post-cardiac surgery neonates, we achieved a sort of balance between production of creatinine and clearance of creatinine, so a 0 delta at the beginning and at the end of the session, by using KT over V of 0.9, so almost 35 milliliters per kilogram per hour. And in this way, after some hours or days of treatment, we were able to have a stable creatinine between 0.5 to 1 milligram per deciliter in our patient. Clearly, it's not creatinine that we are targeting, but once we use it as a measure of quantification of our dose, probably that's enough. It remains the fact that fluid overload prevention is the most important issue in these patients. That brings me to the final part of the speech, where I wanted to touch a little bit of other acute settings. For example, the liver patients, something about plasma exchange in children, a couple of case reports about septic patients, which are very interesting to me. We know that acute liver patients do have renal issues, and another important thing in these patients is that volume control is an important aspect, solute control, and above all we have a solute that we can control and monitor and treat by RRT, which is ammonia. And in this study, Akashdeep showed that applying high volume hemofiltration to these patients, as you can see here, 60 milliliters per kilogram per hour up to 3 liters to these patients, he was able to achieve a significant control of ammonia and then hepatic encephalopathy in these patients. And those who had a reduction in ammonium level after the start of CRT were the one who really survived. So again, if you have to use high volume hemofiltration, you have to have an indication, and you need to have a biomarker to monitor in order to follow and to monitor your therapy. Recently, a lot of patients have been treated with hybrid techniques, such as in this case. These other study on liver patient is very interesting because they applied a sort of incremental intensity of treatment depending on a specific patient. So for example, if they have a simple acute kidney injury liver failure patient, they only applied CRT, again with a high dosage. When the patient was clinically unstable and having some coagulation issues, they stepped up to plasma exchange up to the MARS in the most severely ill liver patient, and in this way they describe it. Okay, so but their results are quite satisfying because their survival is 73%. Again, the survivors are those with the aggressive control of encephalopathy. A few words about plasma exchange has been increasingly used in septic patients. These are two recent reports that are reporting similar results with similar techniques, especially in septic patients who were so severely ill that they were treated by ECMO, and so they had to connect the plasma exchange machine to the ECMO. One of the most important indications currently developing and probably mostly accepted for the treatment of sepsis in children is the so-called TAMOF, that is the thrombocytopenia-associated multiple organ failure. That is a particular form of multiple organ failure where you have this biomarker, the ultra-large Von-Willebrand factor, that is the beast who causes microangiopathies and coagulation derangement. In this case, plasma exchange seems quite reasonable because you have to remove the cause of the septic shock and the multiple organ failure. And in these studies, as I was telling you, they connected the plasma exchange to the ECMO machine, and in some cases to the CRT machine that was connected to ECMO. This is a perfect example of multiple organ support therapy, and to tell you that this is not easy, I have not only to acknowledge that, for example, plasma exchange needed an additional citrate anticoagulation, because when you apply plasma exchange you increase the coagulation issues to your circuit. These are some examples of the treatment. They essentially exchanged 1 to 1.5 times the estimated plasma volume of this patient. But what they clearly tell us is that these kind of treatments are not easy, and as you can see, 8.6% of times they had to stop the treatment due to problems, a complication with the circuits. So we currently strongly need something integrated in order to deliver to these complex but still increasingly treated patients with this kind of therapies. I'm going to conclude quickly with the couple of case reports. This is very interesting. They used this selective cytopheretic device. Essentially, they describe a treatment of a child that after surgery underwent orthopedic surgery, if I'm not wrong, underwent a severe sepsis with propofol syndrome, and they treated her with this particular filter where the blood, after being citrated due to citrate anticoagulation in a low calcium environment, is circulated outside the hollow fiber of this particular circuit. And when I was searching something more about this interesting technology, I found this this interesting picture where you can see these are white blood cells that simply stick outside the whole fiber because they are sort of trapped into this device and they are controlled. In this way, the authors were able to show a sort of balancing of the septic syndrome of this patient who ultimately survived to the episode. Again, another case report, which is not very important in a clinical value because they showed a rapid regression of the septic syndrome in this patient after the application of this treatment. But what hit me is the idea of enhancing the mediator removal by applying in series a high cutoff hemofilter and then a sorbent. In this way, they were able, probably, we don't know because they didn't dose any specific marker, but they were probably able to, or they were attempting to control solid mediators, septic solid mediators in these patients. My final thought is something linked to the adults. Again, an hemoperfusion device. We know from last year presentation that this device was able to show some results in a specific population of severely ill adult patient with the MODS score very high and a specific biomarker level. We know that endotoxemia is very frequent in children, and we dosed in post-CPB infant, and we found that it goes frequently above the higher level of 0.6. So the issue here is that probably we would be able to remove a lot of endotoxin from this patient once we had the correct indication. We are waiting for any specific technology on this. So in conclusion, CRRT in the pediatric setting is a challenge. It is a technical challenge, and it is a challenge because these patients tend, unfortunately, to die a lot. Fluid overload is our main target and should be prevented because we currently do not know if once you have fluid overload, you can actually treat this patient by fluid downloading them. Then we have some important unanswered questions about the pediatric CRT. The timing, again, we have issues about definition of timing and the difference between timing and indication. We do not know the optimal dose. Again, this is very important, not only for solid control, but also because depending on the dose that you prescribe, then you will have the requirement for a specific blood flow rate, and all the technical issue of your machine will depend on that. So my suggestion is not too low, not too much, quite democratic. How to address the fluid download, probably goal-directed. We don't know anything about this. There are specific settings. Probably sepsis and liver failure are the most studied currently. That could benefit by specific treatments, and again, technology is evolving in this field, and we will probably have, I hope, in specific, very specific patient and indication, good results in the next year. I thank you for your attention. Oh, and tomorrow there will be something more on children if you want to come tomorrow afternoon. Thank you for your attention.